Hello everyone, let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we're gonna talk about part 1 of Fleischner Society 2024 Glossary of Terms for Thoracic Imaging. Let's go. Fleischner Society 2024 Glossary of Terms for Thoracic Imaging. This topic is for you who want to know the definition of and the radiographic CAT scan findings of thoracic diseases. Presented with love, Dr. Y. Radiology, reviews and commentary, statements and guidelines. Fleischner Society Glossary of Terms for Thoracic Imaging. Alexander A. Bankier et al. Radiology, Year 2024, Volume 310. Fleischner Society Glossary of Terms for Thoracic Imaging. Members of the Fleischner Society have compiled the glossary of terms for thoracic imaging that replaces previous glossaries published in 1984, 1996, and 2008, respectively. The impetus to update the previous version arose from multiple considerations. These include an awareness that new terms and concepts have emerged, others have become obsolete, and the usage of some terms has either changed or become inconsistent to a degree that warranted a new definition. This latest glossary is focused on terms of clinical importance and on those whose meaning may be perceived as vague or ambiguous. As with previous versions, the aim of the present glossary is to establish standardization of terminology for thoracic radiology and therapy, to facilitate communications between radiologists and other clinicians. Moreover, the present glossary aims to contribute to a more stringent use of terminology, increasingly required for structured reporting and accurate searches in large databases. Compared with the previous version, the number of the images, chest radiograph, CT, in the current version has substantially increased. The authors hope that this will enhance its educational and practical value. RSNA 2024. Achinus, plural, achini, anatomy. The achinus is a structural unit of the lung distal to the terminal bronchiole and is supplied by a first-order respiratory bronchiole with a diameter of approximately 4 to 8 mm. The secondary pulmonary lobule contains between 3 and 25 acini. Within the achinus, all parts are involved in gas exchange, i.e., they contain alveoli. The achinus consists of respiratory bronchioles, alveolar ducts, and alveoli. Normal achini are not visible radiologically, but the accumulation of pathologic material within achini may be seen as small, ill-defined, rounded opacities, sometimes called airspace nodules. Air bronchogram, pathology, and descriptor. Air bronchogram is the descriptive term for air-filled airways within lung parenchyma that is partially or completely airless. The term implies a patency of proximal airways and b. evacuation of alveolar air by means of absorption, e.g., in atelectasis or replacement, for example, fluid tumor, or a combination of these processes. Air bronchogram, pathology, descriptor. On your left side, the arrows indicate the air bronchogram of left lower lobe segmental bronchi in pneumonia patient. On your right side, the arrows indicate air bronchogram of right lower lobe segmental bronchi in pneumonia patients of CAT scan. Air crescent, pathology, descriptor. Air crescent is the descriptive term for a crescent-shaped air collection between the wall of a cavity and a mass within the cavity. It is often associated with the retraction of infarcted lung parenchyma in angio-invasive aspergillosis or with the colonization of pre-existing cavities by aspergillus or other fungi. In the latter case, the resulting fungus spore may be mobile and change position with changes in the patient's position. Air crescents can also occur due to necrotic tissue or a blood clot within a cavity. Air crescent pathology descriptor. The arrows indicate the air crescent in the mycetoma patients of underlying tuberculous cavity. Air trapping, physiology, pathology. Air trapping is retention of air in the lung parenchyma distal to more proximal obstruction of one or several airway. Air or gas trapping is seen at CT performed during or at end of expiration. It is characterized by a less than normal increase in attenuation and B, a less than normal decrease in volume on expiration. Air trapping should only be called on expiratory CT. Of note, areas of air trapping are typically sharply marginated. However, the distinction between air trapping and decreased attenuation due to vascular occlusion, in other words, in chronic thromboembolic disease, may be difficult. Air trapping is also frequently associated with decreased focal perfusion, in other words, caused by reactive vasoconstriction. Air trapping, physiology, pathology. Right side is expiration CT image. The arrows indicate the left lower lobe of lower density of air trapping. Air trapping. The arrows indicate both lower lobe of air trapping on expiration CAT scan. Air trapping. Black arrows of expiration CAT scan indicate left lower lobe air trapping. White arrows on right lower lobe indicate no air trapping on right lower lobe. Airspace anatomy. An airspace is the air, gas-containing part of the lung parenchyma, including the respiratory bronchioles, alveolar ducts, and alveoli, but excluding purely conductive airways, such as terminal bronchioles. The term is used in conjunction with opacity and nodule to designate the accumulation of material within airspace. Airways anatomy. The airways are structural parts of respiratory system that allow airflow. Conducting airways extend from the nares and buccal opening to the terminal bronchioles. Large airways include the cervical and thoracic part of the trachea, as well as the main, lobar, and segmental bronchi. Small airways include the subsegmental bronchi to bronchioles with an internal diameter of less than 2 mm. Diseases of central airways can often be visualized directly at CT, whereas diseases of the peripheral airways often manifest through indirect changes, for example, air trapping. Anatomic distribution, anatomy, bronchocentric, adjacent to or involved in bronchi and the axial interstitium. Centrilobular, centered on core structures of secondary pulmonary lobule, often used to describe distribution of nodules or micronodules. Diffuse, distributed throughout the lobe or lobes without particular regional predominance, i.e. between central and peripheral parts of the lung. Anatomic distribution, anatomy, centrilobular. The arrows indicate the centrilobular. This is hypersensitivity pneumonitis patient. Anatomic distribution, anatomy, centrilobular. The arrows indicate the centrilobular. This is non-tuberculous Mycobacterium pulmonary disease patient. Arrows indicate also centrilobular. This is tuberculosis patient. Another centrilobular, tree in bud. The arrows indicate the centrilobular. This patient is infectious bronchiolitis. Anatomic distribution, anatomy, centrilobular. The arrows indicate centrilobular. This patient is diffuse panbronchiolitis. Last example of centrilobular. The arrows indicate the centrilobular. Anatomic distribution, anatomy, diffuse. We see diffuse ground glass opacity and consolidation of ARDS patient. Anatomic distribution, anatomy, endobronchial, located within lumen of a bronchus. Extrapleural, external to pleural without directly involving pleural or pleural space. Fissural, refers to a lesion or a disease that arises from or involves fissure. A lesion or disease that has direct contact with the fissure but does not arise from it should be called perifissural. Focal, confined to one distinct area. Geographic, distributed in a manner resembling the outline of regions on a map. The term implies well-defined margins between areas of differing attenuation. Anatomic distribution, anatomy, endobronchial. The arrows indicate the endobronchial hamartoma. Anatomic distribution, anatomy, extrapleural. The arrows indicate extrapleural fat. Anatomic distribution, anatomy, extrapleural. The arrows indicate rib origin tumor, extrapleural. Anatomic distribution, anatomy, fissural. Pleural metastasis of minor fissure. Anatomic distribution, anatomy, fissural. These micronodules are fissural, right major fissura, and they are also miliary micronodules of tuberculosis. Anatomic distribution, anatomy, perifissural. The arrow indicates perifissural nodule. Anatomic distribution, anatomy, geographic. The ground glass opacities are geographic in distribution. Anatomic distribution, anatomy, geographic. Bilateral ground glass of geographic distribution. subscribed. Thank you very much. Be healthy, wealthy, and happy. Anatomic distribution, anatomy, multifocal, involving two or more distinct areas. Peribronchovascular, distributed along the bronchovascular bundles. Perilobular, arcade-like or curvilinear opacities that can be related to the margins of secondary pulmonary lobules. Perilymphatic, distributed along lymphatic vessels. Anatomic distribution, anatomy, multifocal. Anatomic distribution, anatomy, peribronchovascular. Arrows indicate peribronchovascular. This patient is lymphangitic carcinomatosis. Another examples of peribronchovascular. These two patients are also lymphangitic carcinomatosis. Anatomic distribution, anatomy, perilymphatic. Arrows indicate the micronodules of a perilymphatic distribution. This patient is sarcoidosis. Anatomic distribution, anatomy, perilymphatic. The arrows indicate micronodules of perilymphatic distribution. This patient is co-workers pneumoconiosis. Arrows indicate the perilymphatic distribution of micronodules. This is another patient of pneumoconiosis. Anatomic distribution, anatomy, plural, refers to a lesion or disease that arises from or involves the pleura. A region or disease that has contact with pleura but does not arise from it should be called pleural-based. The term subpleural should only be used for lesions or diseases in proximity to pleura, but without direct contact to it. Because this term has been attributed variable meanings in literature, the term peripheral is preferred to describe such regions or diseases. Of note, imaging cannot always determine whether a given lesion is located between two layers of pleura or within pleura, or in parenchyma and directly contiguous to pleura. Anatomic distribution, anatomy, plural. The arrows indicate the plural. This lung cancer patient shows malignant pleural metastasis and effusion. Anatomic distribution, anatomy, plural. The arrows indicate pleural nodules of pleural metastasis. Anatomic distribution, pleural-based. The arrow indicates pleural-based focal lung collapse. From the Wikipedia, Primavera, the spring, Sandro Botticelli, 1470, Tempera on Panel, Uffizi, Florence, Italia. Quit smoking? Your great job of the year. Congratulations. Hello guys, nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Fleischner Society 2024 Glossary of Terms for Thoracic Imaging, Part 2. Let's go. Fleischner Society 2024 Glossary of Terms for Thoracic Imaging. This topic is for you. Radiology, Reviews and Commentary, Statements and Guidelines, Fleischner Society, Glossary of Terms for Thoracic Imaging, Alexander A. Bankier et al., Radiology 2024, 310. Aortopulmonary window anatomy. The aortopulmonary window is a mediastinal compartment delimited anteriorly by ascending aorta, posteriorly by descending aorta, cranially by aortic arch, caudally by left pulmonary artery, medially by the trachea and the lateral wall of left main bronchus, and laterally by medial pleura covering left lung. The AP window contains lymph nodes and connective tissue and is traversed by left phrenic nerve, left vagus nerve, left recurrent laryngeal nerve, and left bronchial arteries. It is separated into a medial and lateral part by ligamentum arteriosum. Aortopulmonary window anatomy. The arrows indicate aortopulmonary window, and the last one is showing us enlarged pathologic lymph node of AP window, number 5 lymph node of metastatic state. Apical cap pathology. Apical caps are cap-like rims at lung apices, often bilateral, usually caused by pulmonary and/or pleural fibrosis displacing extrapleural fat, chronic ischemia causing a plaque of elastotic fibrosis of the visceral pleura with or without subpleural lung parenchyma has been suggested as potential pathogenesis, which is variably associated and aging. In addition, apical caps can be caused by fluid collections associated with infection, neoplasms, or trauma, either extrapleural or within the pleural space. A left apical cap can be caused by hematoma, such as resulting from aortic rupture. Moderate or severe apical pleural caps also can be seen in upper lobe fibrosis, including pleural parenchymal fibroelastosis. Apical cap pathology. The arrows indicate apical cap. Architectural distortion pathology. Architectural distortion is characterized by defocal or diffuse derangement of the normal pulmonary anatomy, with abnormal displacement or disruption of airways, vessels, and interstitium. It is typically accompanied by volume loss and is commonly seen in fibrotic lung diseases. Architectural distortion pathology. Arrows indicate the architectural distortion in thin section lung window settings of ILD patients. Asbestosis pathology. Asbestosis is an occupational lung disease characterized by lower lobe dominant pulmonary fibrosis caused by inhalation of asbestos fibers. Once established, fibrosis can progress. However, even without progression, the risk of lung cancer is increased. In addition, asbestos exposure increases the risk of mesothelioma. However, asbestosis is usually associated with high levels of asbestos exposure, in distinction to mesothelioma. Although pleural plaques, calcified or non-calcified, may also be identified, their presence is not essential for the diagnosis. Aspiration pathology. Aspiration is the unintended inhalation of solid and/or fluid substances, aspirate, depending on its location and extent within the airways. The aspirate can cause atelectasis, inflammation, aspiration pneumonitis, bronchiolitis, or infection, aspiration pneumonia. Changes caused by aspiration are most commonly seen in the posterior portions of the lungs and predisposed to infection with anaerobic bacteria. Sequelae of aspiration, including scarring and bronchiectasis, can be seen in variable anatomic locations but tend to follow the direction of the gravity. Atelectasis pathology. Atelectasis is a partial or complete collapse of the lung. Atelectasis can be caused by loss of negative pressure in the pleural space and/or by compression of the lung parenchyma, for example, by pleural effusions, by resorption of air following obstruction, for example, by foreign body or neoplasm, or by an increase in alveolar surface tension, for example, by surfactant dysfunction. Atelectasis shows a lower volume and higher attenuation than normal lung tissue, and is often associated with abnormal displacement of fissures, bronchi, vessels, hyperinflation of adjacent lobes, or obscuration of cardiac and mediastinal interfaces. Atelectasis pathology. Lobar. Atelectasis of an entire pulmonary lobe. Linear. Formerly plate-like, band-like, descriptor for local atelectasis with a linear, plate-like or band-like shape, often seen in dependent lung regions, paralleling the hemidiaphragms on chest radiographs and chest wall on CT examination. Of note, the geometric definition of line refers to an one-dimensional structure, while the cross-sectional appearance of an atelectasis may appear linear. The atelectasis itself has greater dimensionality than a line. Atelectasis pathology. Lobar. Right upper lobe collapse due to non-small cell lung cancer of right upper lobe. Atelectasis pathology. Lobar. Left upper lobe collapse due to squamous cell carcinoma of the left upper lobe. Atelectasis pathology. Lobar. Arrow indicates right upper lobe collapse due to chronic endobronchial tuberculosis. Atelectasis pathology. Lobar. Arrows indicate the right middle lobe collapse due to chronic endobronchial inflammation. Atelectasis pathology. Lobar. Arrows indicate the right lower lobe collapse due to chronic endobronchial inflammation. Atelectasis pathology. Lobar atelectasis. Arrow indicates left lower lobe collapse due to endobronchial tumor. Atelectasis pathology. Linear, formerly plate-like, band-like atelectasis. Arrow indicates linear atelectasis. Atelectasis pathology. Linear. Both arrows indicate both lower lobe linear atelectasis. Atelectasis pathology. Rounded. Rounded portion of a collapsed lung associated with invaginated fibrotic pleural and thickened and fibrotic interlobular septa. Rounded atelectasis is consequence of chronic or recurrent pleural effusions as seen in asbestos-related disease, chronic cardiac or renal failure, or thoracic malignancies. At imaging, rounded atelectasis presents as a rounded mass abutting the pleura associated with adjacent pleural thickening. Distorted vessels and bronchi converging toward atelectasis can have a curvilinear appearance, comet-tail sign. It is most commonly seen in the posterior lower lobes. Atelectasis pathology rounded. Arrows indicate rounded atelectasis. In other words, comet-tail sign. Atelectasis pathology segmental. Atelectasis of an anatomical segment of the lung. Subsegmental. Atelectasis of an anatomical subsegment of the lung, which often appears linear. Atelectasis pathology subsegmental. Arrows indicate subsegmental linear atelectasis. Atelectasis pathology subsegmental linear. Both arrows indicate subsegmental linear atelectasis. You subscribed and liked. Thank you very much. Be healthy, wealthy, and happy. Ator sign pathology descriptor. The Ator sign is the descriptive term for a focal ground glass opacity surrounded by a partial or complete ring of consolidation. It is a nonspecific sign originally described in organizing pneumonia and reported subsequently in various other lung diseases. A synonymous term is the reversed halo sign. Ator sign pathology descriptor. Arrows indicate Ator sign in axial and coronal CAT scan. Ator sign pathology descriptor. Arrow indicates Ator sign in organizing pneumonia. Agiophageal recess. Anatomy. Agiophageal recess is right posterior mediastinal recess into which medial part of right lower lobe extends. It is limited cranially by agios arch, posteriorly by agios vein and pleura anteriorly to vertebral bodies, and medially by esophagus. On frontal radiographs, medial part of the recess can be seen as a vertically oriented interface between the right lower lobe and esophagus, and superior part of recess is seen as a smooth arc with convexity to the left at interface with agios vein. Distortion or obliteration of interface can reflect the disease, for example, adenopathy or neoplasm. At CT, the recess merits attention because small lesions located in recess are often invisible on radiographs. Agiophageal recess anatomy. Arrows indicate the agiophageal recess on axial CT scan and frontal chest radiograph. Bleb pathology. A bleb is a circumscribed air-containing cystic structure, exclusively pleural in location and usually sub-centimeter in size. Blebs have been associated with small airway disease and occurrence of pneumothorax, notably in patients with active tobacco use. Small blebs are more readily appreciated with pathology than with the imaging. Bleb pathology. The arrows indicate two blebs on right upper lobe in the pneumothorax patient. Bleb pathology. The arrows indicate 2 cm bleb on right upper lobe in the pneumothorax patient. Blood flow redistribution pathology. Blood flow redistribution is the non-specific term for changes in blood flow seen on both radiographs and CT examinations, reflecting regional redistribution resulting from pathologic conditions such as volume overload or chronic heart failure. Bronchial anatomy. Bronchioles are non-cartilage containing peripheral airways. Terminal bronchioles are most distal of purely conducting airways. They give rise to respiratory bronchioles, from which alveoli arise. Respiratory bronchioles allow gas exchange and branch into multiple alveolar ducts. Normal bronchioles are not visible using current CT techniques. However, in diseases of peripheral airways, bronchioles with thickened walls and/or plugged bronchioles can become visible as nodular opacities on radiographs and/or as tree-in-bud opacities on CT exam. Infection and inflammation of bronchioles are commonly referred to as bronchiolitis. Bronchial anatomy, tree-in-bud. Arrows indicate tree-in-bud appearance of tuberculosis patient. Bronchiectasis pathology. Bronchiectasis indicates a clinical condition of irreversible bronchial dilatation. In the absence of established chronicity, we recommend using the term bronchial dilatation. Bronchiectasis can be secondary to chronic inflammation, congenital, or caused by chronic infection and obstruction of more central airways. It is often accompanied by bronchial wall thickening and/or mucoid impaction. SCT bronchiectasis manifests as dilatation of bronchs relative to accompanying pulmonary artery, signet ring sign, lack of tapering, presence of visible bronchi within 1 cm of pleural surface, tram tracking. Bronchial walls can be thickened and accompanied by scarring of adjacent parenchyma. Bronchiectasis pathology, tram track. Arrows indicate tram track of bronchiectasis in left lower lobe. Bronchiectasis pathology, tram tracking. Arrows indicate tram tracking on left lower lobe bronchiectasis on CT scan. Bronchiectasis pathology, cystic bronchiectasis. Arrows indicate cystic bronchiectasis of right lower lobe in frontal radiograph and CAT scan. Bronchiectasis pathology, traction bronchiectasis pathology, dilatation of the bronchial lumen associated with thickened, irregular bronchial walls caused by fibrosis. This term should only be used in the context of fibrosis. Traction bronchiectasis pathology, dilatation of bronchioles within the central portion of the secondary pulmonary lobule, typically associated with fibrosis and honeycombing. Bronchiectasis pathology, traction bronchiectasis. 3 arrows indicate traction bronchiectasis in UIP patient. Bronchiectasis pathology, traction bronchiectasis. Arrow indicates traction bronchiectasis in ILD patient. Bronchiectasis pathology, traction, bronchiectasis. Arrows indicate traction, bronchiectasis. Traction, bronchiectasis. Two white arrows indicate traction, bronchiectasis of right lower lobe. Bronchiectasis pathology, traction, bronchial ectasis. Arrows indicate traction, bronchial ectasis in ILD patient. Bronchiectasis pathology, traction, bronchial ectasis. Arrows indicate the traction, bronchial ectasis in interstitial lung disease patient. Bronchial ectasis. Arrows indicate bronchial ectasis. Bronchiectasis pathology, signet ring. Arrows indicate signet ring sign of bronchiectasis in right lower lobe. Bronchocele pathology. A bronchocele is a focal bronchial dilatation, often with mucoid impaction. Bronchoceles can be either congenital, for example in bronchial atresia, or caused by retained secretions or proximal obstruction, for example by an endobronchial tumor. At CAT scan, bronchoceles are typically branching V or Y-shaped structures that may have a finger-like appearance. In bronchial atresia, the surrounding lung parenchyma can have low attenuation because of reduced ventilation and thus decreased perfusion. Bronchocele pathology. Arrows indicate bronchocele with mucoid impaction in right lower lobe. Bronchocele pathology. Arrows indicate bronchocele with mucoid impaction in right upper lobe of bronchial atresia patient. Bronchocele pathology. Arrows indicate Y-shaped bronchocele with mucoid impaction in right lung. Bronchocele pathology. Arrows indicate V-shaped bronchocele with mucoid impaction in right upper lobe. Broncholith pathology. A broncholith is calcified material within bronchial lumen, generally caused by erosion of a peribronchial lymph node into the lumen, and most commonly a result of previous granulomatous infection. Broncholith manifest when calcified lesions directly adjacent to or within bronchial wall erode into the lumen. They can be accompanied by distal atelectasis, bronchiectasis, or mucoid impaction. Broncholith pathology. Arrows indicate broncholith and bronchial dilatation. Bronchomalacia pathology. Bronchomalacia is mechanical weakening of bronchial cartilage, either congenital or caused by chronic inflammation and damage, leading to excessive bronchial collapsibility of approximately 70 to 80% of original luminal diameter, subsequent ventilatory impairment. Excessive collapsibility is best confirmed with a dynamic CT performed during first expiration. Bronchomalacia is often associated with the same phenomenon in tracheomalacia and can be accompanied by thickening of airway walls. Of note, a substantial degree of collapse may also occur in healthy individuals. Bulla, plural bullae pathology. A bulla is a circumscribed air-containing cystic structure in the lung parenchyma, lined by a thin layer of collapsed lung parenchyma. It is caused by dilatation, destruction, and conference of air spaces distal to terminal bronchioles. At imaging, a bulla typically appears as a rounded lucency with a very fine and usually smooth wall. Bulla, plural, bullae, pathology. Arrows indicate the bullae of right upper lobe. We have enjoyed this wonderful painting of Botticelli, the Primavera, the Spring. Please pay more attention between the space between Cupid and Venus in the center of the painting. What do we see? Or what do you see? Do we see chest radiograph? You quit smoking? You did a great job of this year. Congratulations. See you soon on part 3. Hello friends, nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we're going to talk about the part 3 of Fleischner Society 2024 glossary of terms for thoracic imaging. Let's begin. This topic is based on the radiology, reviews and commentary, statements and guidelines, Fleischner Society glossary of terms for thoracic imaging by Alexander A. Benkier et al. Radiology 2024 310. This topic is for you who want to know the definition of and the radiographic CAT scan findings of the thoracic diseases. Now let's start. Cavity. Pathology. A cavity is an abnormal gas or fluid-filled structure with a typically thick and often irregular wall, usually produced by expulsion or drainage of a necrotic part of the lesion by a bronchial tree. It may be isolated or associated with adjacent lung pathology, and a gas fluid level may be present in the cavity. Cavities are to be differentiated from pseudocavities. A pseudocavity appears as an area of low attenuation in the nodules, masses, or consolidations that represent spared parenchyma, normal or ectatic bronchi, or emphysema rather than cavitation. Cavity pathology. Arrows indicate the cavity of tuberculosis. Cavity pathology. Both arrows indicate the cavities in the lung cancer of squamous cell carcinoma. Cavity pathology. Pseudocavity. Both arrows indicate the pseudocavities in the ground glass nodule of adenocarcinoma. Cavity pathology, pseudocavity. Arrow indicates pseudocavity in the ground glass nodule of adenocarcinoma in right lower lobe. Consolidation pathology descriptor. Consolidation refers to increased attenuation of lung parenchyma resulting from evacuation of air from alveoli and its replacement by fluid or other material. On radiographs, consolidation appears as a homogeneous increase in attenuation. At CT, it is defined as opacity causing complete obscuration of underlying bronchi and vessels, the latter only on on enhanced CT examinations. Patent bronchi within consolidation may form air bronchograms. The term is a descriptor that does not indicate the pathologic nature of condition causing consolidation. Consolidation pathology descriptor. The arrows indicate the right middle lobe consolidation on chest radiograph and a CAT scan. Consolidation pathology descriptor. Arrows indicate the consolidation in right lower lobe at CAT scan. Consolidation and ground glass opacity. Black arrows indicate consolidation and white arrows indicate ground glass opacity in right lower lobe of pneumonia. Cyst pathology. A cyst is any circumscribed and well-defined air-containing structure in the lung parenchyma. Cysts can originate from mechanisms such as airway obstruction with distal airspace dilatation, check valve mechanism, necrosis of airway walls, or lung parenchymal destruction by proteases. A small number of lung cysts may be seen with aging. At imaging, a cyst appears as a circumscribed and well-defined radiolucency and/or low attenuation area with a thin and usually regular wall. Most cysts contain air, but they can occasionally contain fluid or solid material. Of note, radiologic and pathologic definitions of cyst differ. Cyst pathology. Arrows indicate cyst, lung cyst. On your right side, this patient is LAM, lymphangioliomyomatosis. Cystic pathology descriptor. Cystic is descriptive adjective designating lesions characterized by central air equivalent attenuation, surrounded by a wall of variable thickness and regularity. There is unavoidable morphologic overlap between structures commonly described as cystic, bulla, flap, cyst due to lack of objective criteria to quantify wall thickness of these structures, and because of a multitude of currently proposed definitions rather than a decisive consensus in the literature. As the cause of cystic lesions is often difficult to determine at CT, the term cystic can be used as a descriptor without implying etiology. Cystic pathology descriptor. Both arrows indicate cystic lung cancer. Both lesions are from squamous cell carcinoma of the lung. Embolism, embolus, emboli, pathology. Embolism refers to pathologic lodging of a partially or completely obstructing material, embolus, inside the blood vessel. The embolus may be a blood clot, i.e. a thrombus, fat embolism, air or another gas embolism, amniotic fluid embolism, infectious material septic embolism, neoplastic tissue tumor embolism, or a foreign body. On ventilation perfusion scans, areas affected by the embolism appear as a mismatch between BP scans with a ventilated perfusion defect. Partial or complete vascular occlusion caused by embolism may cause necrosis of lung distal to embolus, infarction. Embolism, embolus, emboli, pathology. White arrow indicates embolism in left lower lobe pulmonary artery branch. Black arrow indicates infarction area in left lower lobe. Emphysema pathology. Emphysema is characterized by irreversible enlarged air spaces distal to and originating from the terminal bronchioles with destruction of alveolar walls. The absence of fibrosis was historically regarded as an additional criterion, but this is no longer the case because local fibrosis is now recognized to coexist with emphysema both histologically and at imaging. Emphysema is pathologically classified according to the anatomic area predominantly affected. Emphysema pathology, centrilobular, focal emphysematous destruction that originally affects the center of a secondary pulmonary lobule and, if progressive, can eventually involve the entire lobule. Even if severe, centrilobular emphysema tends to respect the borders of the lobule, which are not destroyed. On CT examinations, early centrilobular emphysema is characterized by small areas of low attenuation surrounded by normal lung, without clearly defined walls, often with upper lobe predominance. When progressive, larger areas of low attenuation can span several secondary pulmonary lobules. Emphysema pathology, centrilobular. Arrows indicate the centrilobular emphysema. Amigos, you subscribed and liked. Thank you very much. Panlobular, diffuse emphysematous destruction across the secondary pulmonary lobule, the structures of which are effaced, sometimes with a lower lobe predominance. On CT exam, panlobular emphysema is characterized by larger and/or diffuse areas of low attenuation, where components of the normal lung architecture, and notably those of the secondary pulmonary lobule, are no longer recognizable. Emphysema pathology, panlobular. Black arrows indicate panlobular emphysema. Emphysema pathology, panlobular. These two patients show panlobular emphysema. Emphysema paraseptal, focal emphysematous destruction of the distal ischias, typically located near the pleural surface, close to the chest wall, mediastinum, and interlobar fissures. On CT exam, paraseptal emphysema is characterized by foci of low attenuation, separated by intact interlobular septa, thickened by associated mild fibrosis. Architectural distortion is typically absent. Emphysema pathology, paraseptal. Arrows indicate paraseptal emphysema on chest X-ray and CAT scan. Emphysema pathology, paraseptal. Arrows indicate paraseptal emphysema without architectural distortion. Emphysema pathology. In addition to pathologic definition of emphysema, visually defined CT subtypes of emphysema have been described. The terms interstitial emphysema and subcutaneous emphysema are sometimes used to designate abnormal air collections in the pulmonary interstitium and the soft tissue, respectively, as may result from barotrauma. These abnormalities are distinct processes and are not related to the destruction of the lung parenchyma. Empyema pathology. Empyema is a collection of pus and pleural space most often occurring as a complication of pneumonia or esophageal perforation. Empyema is commonly unilateral. On CT exam, the fluid collection may contain locules of gas and pleura is thickened and enhances after IV contrast administration. At margins of empyema, the pleura can be seen dividing into its visceral and parietal layers. This is referred to as split pleural sign, which can occasionally help to distinguish an empyema from a pneumonic effusion or a peripheral lung abscess. Empyema pathology, split pleural sign. Arrows indicate both sides of pleura. Lateral one is parietal pleura and medial one is visceral pleura. Fibrosis, adjective, fibrotic, pathology. Fibrosis is a general term for a repair mechanism of the lung in which parenchyma is permanently replaced by connective tissue, causing remodeling, architectural distortion, and volume loss. Other CT signs of fibrosis include traction bronchiectasis or bronchial ectasis and potentially honeycombing. Fibrosis can be the result of mechanical, inflammatory, infectious, or iatrogenic damage. It can be focal or diffuse in distribution and is often accompanied by functional impairment. Fibrosis, pathology. CAT scan shows bilateral pulmonary fibrosis of idiopathic pulmonary fibrosis patient. A fissure, anatomy. A fissure is a structure consisting of two layers of infolded visceral pleura that separates the lobes. The left major oblique fissure separates the left upper lobe and left lower lobe. The right minor horizontal fissure separates the right upper lobe and right middle lobe. The right major and oblique fissure separates the right lower lobe from the right upper lobe and right middle lobe. On CT exam, normal fissures are seen as thin and regular lines. Fissure anatomy, minor and major fissures. This is the axial image of CAT scan. White arrow indicates minor fissure. Black arrows indicate major fissures. This is coronal CAT scan. White arrow indicates minor fissure. Black arrows indicate major fissures. This is the right lung sagittal CAT scan. White arrows indicate minor fissure and black arrows indicate major fissure. Fissure anatomy, accessory supernumerary fissures usually separating segments rather than lobes. Adjective, developmental variant consisting of a fold of a pleura pulled through a lung towards hilum by a non-migrating right posterior cardinal vein, one of embryological precursors of adjacent vein. Because adjacent fissure has two visceral and two parietal layers, it is in fact a pseudofissure. Incomplete, partial absence of a fissure between two lobes. Incomplete fissures allow collateral ventilation between two lobes. Therefore, their detection is relevant, for example, before emphysema treatment with endobronchial occlusive devices. Fissure anatomy, accessory, and incomplete fissure. On your left side, arrows indicate accessory fissure. On your right side, arrows indicate incomplete fissure of right major fissure. Fissure anatomy, azygous fissure. Arrows indicate azygous fissure. Ground glass, physiology and pathology. Ground glass refers to an area of increased attenuation that does not completely obscure underlying bronchial and vascular structures. Although historically first described in radiographs, specifics of this term have been defined for CT, and it should only be applied in context of CT. Accurate identification of a ground glass opacity requires thin section CT less than 1.5 mm acquired at full inspiration, preferably reconstructed with a high spatial frequency algorithm and displayed with wide window width. The findings is nonspecific, as ground glass can be caused by any abnormal process below resolution of CT scanner that does not completely displace alveolar air, for example, partial filling of alveoli by fluid or cellular material, an increase in capillary blood volume, histologic fibrosis, lipidic pattern of adenocarcinoma, or a combination of the above. Ground glass nodule, physiology, pathology. Arrows indicate ground glass nodule in left lower lobe. This is adenocarcinoma. Ground glass opacity, physiology, pathology. Arrows indicate ground glass opacity. This patient is COVID pneumonia. Ground glass opacity, physiology, pathology. Arrows indicate ground glass opacity in the IPF patient. Ground glass opacity. Arrows indicate ground glass opacity of alveolar pneumonia patient. Halo, pathology. A halo is a rim of ground glass opacity surrounding a nodule, mass, or consolidation. The presence of a halo is nonspecific, but often reflects local hemorrhage around an infectious or neoplastic lesion, for example, invasive aspergillosis or lipidic tumor growth, for example, primary adenocarcinoma. Halo pathology, angio-invasive aspergillosis. Arrows indicate the halo. Hilum, plural hyla, adjective hyla, anatomy. The hilum is the site at the medial aspect of the lung, which is not covered by visceral plural, adjacent to the mediastinum, where vessels and bronchi enter and leave the lung. The hilum contains bronchi, arteries, veins, lymphatic vessels, lymph nodes, nerves, and other structures. Hilum anatomy. These two yellow squares indicate hilum. Both sides of hilum, right and left. Left side is a little higher than the right side. Honeycombing, pathology. Honeycombing represents destruction of the lung parenchyma with a loss of architecture and well-defined adjacent cystic structures, typically clustered in the subpleural region. The traditional definition requires several layers of cysts, but in current practice, this threshold has been reduced to a single layer of cysts, provided other signs of fibrosis are present. The diameter and wall thickness of the cysts are variable, but their presence is inevitably accompanied by complete effacement of normal lung architecture and usually occurs with other signs of pulmonary fibrosis, including traction bronchioloectasis. Honeycombing pathology. Of note, Honeycombing can also exist at the microscopic level and does not necessarily reflect the CT appearance of honeycombing. Care should be exercised when using the term honeycombing, as it implies substantial fibrosis, and the term should only be used if other signs of fibrosis are present. Honeycombing pathology. Arrows indicate the honeycombing. Honeycombing pathology. We are watching the honeycombing in right lower lobe of IPF patients. You quit smoking? Your greatest job of the year. Congratulations. See you soon on part 4. Hello, my friends. Nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we're gonna talk about the part 4 of the Fleischner Society 2024 glossary of terms for thoracic imaging. Let's go. This topic is based on the radiology, reviews and commentary, statements and guidelines, Fleischner Society Glossary of Terms for Thoracic Imaging by Alexander A. Benkier et al. Radiology 2024, 310. This topic is for you who want to know the definition of and the radiographic CAT scan findings of the thoracic diseases. Infarction pathology. Infarction is the result of parenchymal damage from vascular obstruction or occlusion caused by either emboli or pathologic changes of a vessel wall. At imaging, a pulmonary infarct is typically a triangular dome or wedge-shaped opacity with base abutting the pleura and apex directed toward hilum. The opacity reflects the local hemorrhage or edema and necrosis and late organization and or scarring, or a combination of these, depending on timing of imaging during natural history of vascular occlusion, embolus. However, many infarcts seen in acute pulmonary embolism are due to edema and hemorrhage without necrosis and hence are not true infarcts. Interstitial lung abnormality pathology. Interstitial lung abnormality is an umbrella term used for often subtle interstitial CT abnormalities in non-dependent parts of the lungs, detected incidentally. They often manifest as variable combinations of peripheral ground glass opacity and reticular opacities, which should affect more than 5% of upper, middle, or lower lung zone, as demarcated by levels of inferior part of the aortic arch and right inferior pulmonary vein, respectively. The term is not necessarily associated with presence of respiratory symptoms. Interstitial lung abnormality pathology. Arrows indicate both lower lobe posterior portion, the interstitial lung abnormality. Interstitial lung abnormality pathology. Arrows indicate the site of interstitial lung abnormality and right lower lobe. Interstitial lung disease pathology. Interstitial lung disease is an umbrella term used for a large group of lung diseases that involve the interstitium and are typically associated with restrictive pulmonary impairment. These conditions are, in fact, very often multi-compartmental and may then also involve the pulmonary airspaces, airways, and vasculature to varying degrees, and some may result in pulmonary fibrosis. Interstitium anatomy. The interstitium consists of a continuum of connective tissue extending from most central to most peripheral components of the lung parenchyma, which mechanically supports the airways, vascular structures, and alveoli. Anatomically, it forms a single interconnected space encompassing entire lung. For didactic reasons, it is divided into three compartments. 1. Axial, portion of interstitium that envelops airways, vascular structures, and lymphatic vessels, the combination of which are sometimes referred to as bronchovascular bundle. 2. Interlobular, peripheral, portion of the interstitium that extends from the visceral pleura and forms the envelope of the secondary pulmonary lobule and is visible as interlobular septa on CT examinations. 3. Intralobular septa, portion of the interstitium within the secondary pulmonary lobule that serves as the support structure for alveolar walls. Irregular anatomy pathology descriptor. Irregular is a general term describing the margination of a structure, for example, a pulmonary nodule or its components, as not smooth and or uneven. More precise descriptors falling under this general term include lobulation and speculation. Juxtaphrenic peak anatomy. Juxtaphrenic peak is a small triangular opacity based on either the right or the left hemidiaphragm, with its tip pointing toward the lung apex, caused by upward retraction of an inferior accessory fissure or an intrapulmonary septum associated with the pulmonary ligament pleura. The retraction reflects the volume loss in the ipsilateral upper lobe, for example, after radiation or surgery. The peak is best visualized on frontal radiographs and coronal CT reconstructions. Juxtaphrenic peak anatomy. Arrow indicates juxtaphrenic peak in right upper lobe lobectomy patient. Lobe anatomy. The lobes are the principal divisions of the lungs. The right lung has 3 lobes and the left lung has 2 lobes. Each lobe is enveloped by visceral pleura, except at the hilum or when an interlobar fissure is incomplete. Lobulation anatomy, pathology, and descriptor. Lobulation is the descriptive term referring to a lobule-like and often asymmetric protrusion at margins of a structure, for example, a pulmonary nodule or its components. Pathologically, lobulations often reflect different rates of tissue growth or the presence of different tissues within the same structure, and typically have smooth margins. Although lobulation is often seen in malignant nodules or masses, it can also occur in benign lesions. Lobulation anatomy, pathology, descriptor. Arrows indicate the lobulation of lung nodule. Lymph node anatomy. Lymph nodes are organs of the lymphatic system surrounded by a fibrous capsule and divided into outer cortex and inner medulla. The hilum is an indentation on concave surface of lymph node where lymphatic vessels exit and blood vessels both enter and exit. Normal lymph nodes are best seen on CT exam where they appear as round, oval, bean-shaped structures. sometimes with a visible fatty hilum. For purposes of cancer staging, mediastinal, hilar, and intrapulmonary lymph nodes are classified according to anatomic stations. Lymph nodes present in the lung parenchyma are called intrapulmonary lymph nodes. They are typically lobular and triangular in outline and occur along pleural surfaces, interlobular septa, and at vascular branching points. Aggregates of lymphatic tissues without capsule, as commonly seen along pleural fissures, are, strictly speaking, not lymph nodes. Lymph node anatomy. Arrow indicates normal fatty hilum of paratracheal lymph node. Lymphadenopathy pathology. Lymphadenopathy refers to any pathologic transformation of lymph node with regard to size, shape, and morphology. In more common usage, the term refers to abnormal enlargement of lymph node. Therefore, the synonym lymph node enlargement is more precise and thus preferable. On CT exam and depending on clinical scenario, the somewhat arbitrary threshold of either 10 or 15 mm short X diameter is often regarded as upper limit of normal. Because lymph nodes commonly show a wide range of sizes according to location, differentiation between normal and diseased lymph node based on size alone is unreliable and should be complemented by consideration of location and morphologic features or with assessment of metabolic activity by FDG PET-CT. Lymphadenopathy pathology. Arrows indicate right interlobar lymph node and subcarina lymph node enlargement due to right upper lobe adenocarcinoma of lung cancer. Lymphadenopathy pathology. Arrows indicate lymph node enlargement, lymphadenopathy of sarcoidosis patient. Mass pathology. A mass is any circumscribed lesion bigger than 30 mm in diameter. The term usually refers to a predominantly solid soft tissue structure, but cavitary, cystic, or calcified components may be present to various degrees. Shape and margin descriptors are similar to those used for pulmonary nodules. In addition, distortion or invasion of adjacent structures may be present. The adjectival term mass-like, for example, used in mass-like consolidation, may be used to describe appearance of a given lesion without implying a neoplastic etiology. Mass pathology. We see two masses in right upper lobe and left lower lobe, more than 3 cm, actually 8 or 9 cm in length, of lung cancers. Mediastinum anatomy. Mediastinum is an anatomic space located between lungs and extending from thoracic inlet to diaphragm. The current definition of mediastinal compartments is based on CT criteria and includes prevascular anterior, visceral middle, and paravertebral posterior compartments. Mediastinum prevascular compartment anatomy. Boundaries of prevascular compartments are superiorly thoracic inlet, inferiorly diaphragm, anteriorly sternum, laterally parietal mediastinal pleura, and posteriorly anterior aspect of pericardium as it wraps around in a curvilinear fashion. Thus, any vessels contained within pericardium are located in visceral mediastinum. The major contents of prevascular compartment are thymus, fat, lymph nodes, and left brachiocephalic vein. Mediastinum visceral compartment anatomy. Boundaries of the visceral mediastinum are superiorly thoracic inlet, inferiorly diaphragm, anteriorly anterior aspect of pericardium, which envelopes distal aspect of superior vena cava, proximal aspect of ascending aorta, and lateral rim of aortic arch and intrapericardial pulmonary artery. Posteriorly, a vertical line connecting a point on thoracic vertebral bodies 1 cm posterior to anterior margin of spine. The major contents of this compartment fall into two main categories. First, a vascular category, in other words, heart, superior vena cava, ascending thoracic aorta, aortic arch, descending thoracic aorta, intrapericardial pulmonary arteries, thoracic duct, and second, trachea, carina, and esophagus, which share an embryological origin, endodome, as well as lymph nodes. Mediastinum, paravertebral compartment anatomy. Boundaries of the paravertebral posterior compartment are superiorly the thoracic inlet, inferiorly the diaphragm, anteriorly the visceral compartment, and posterolaterally a vertical line along the posterior margin of the chest wall at the lateral aspect of the transverse processes. The major contents of this compartment are the thoracic spine and paravertebral soft tissues. Micronodule pathology. Micronodule is circumscribed and typically round opacity, previously defined as less than 3 mm, but currently defined as less than 6 mm in average diameter. This size threshold serves to distinguish micronodules, if found incidentally, from larger potentially actionable nodules, compatible with current management guidelines. In patients with a high risk for cancer or with an underlying history of cancer, micronodules can become actionable, notably if newly appeared. Micronodules can show same shape and margin, as well as structure and location characteristics as nodules. However, in case of micronodules, these characteristics can be difficult or impossible to assess accurately because of their small size. Of note, concept of individual micronodules is different from concept of micronodular pattern. Micronodule pathology, miliary and random. Arrows indicate micronodules from miliary tuberculosis. Micronodules pathology. We see many micronodules of miliary tuberculosis. Micronodule pathology, miliary metastasis. And these micronodules are miliary in pattern of lung metastasis. You subscribed and liked. Thank you very much. Be healthy, wealthy, and happy. Mosaic attenuation pathology. For description, see pattern mosaic. The mosaic attenuation CT pattern can be caused by obliterative small airway disease, occlusive vascular disease, multifocal interstitial lung disease, or by a combination of the above. In obliterative small airway disease and in occlusive vascular disease, the lower attenuation areas are abnormally hypodense and the higher attenuation abnormally hyperdense, reflecting differences in vascular perfusion, whereas in multifocal interstitial lung disease, the lower attenuation areas are normal and the higher attenuation areas are abnormal. Mosaic attenuation should only be described on CT exam performed in full inspiration. Mosaic perfusion refers to mosaic pattern caused by local variations in lung perfusion. Mosaic attenuation pathology. Arrows indicate the mosaic attenuation of lower density. Mosaic attenuation pathology. Arrows indicate the mosaic attenuation in another patient. Arrows indicate mosaic attenuation in a different patient. Mucoid impaction pathology, also referred to as mucus plugging. Mucoid impaction represents airway filling by mucoid secretions and can be obstructive or non-obstructive. It is often combined with signs of chronic airway disease. Mucoid impaction. Arrows indicate mucoid impaction of Y-shaped in CAT scan and chest X-ray. Mycetoma, fungus ball pathology. Mycetoma is a mass of intertwined hyphae, usually of an Aspergillus species, matted together by mucus, fibrin, and cellular debris, colonizing a pre-existing cavity. At imaging, mycetoma appears as a rounded structure within the cavity, often showing an air crescent between mass and inner wall of the cavity. On CT exam, mycetoma can have a sponge-like structure and calcifications may be present. Mycetomas are often mobile and changes in position within the cavity can be confirmed by imaging the patient in a different body position, for example, supine and prone. Mycetoma pathology. Arrows indicate air crescent sign of mycetoma. Nodule pathology. A nodule is a circumscribed, typically round opacity, less than 30 mm in average diameter. A rounded lesion more than 30 mm is referred to as a mass. A rounded lesion less than 6 mm in diameter should be called micronodule, a term which serves to distinguish it from larger, potentially actionable nodules compatible with current management guidelines. The terminology described below is intended to standardize the description and reporting of nodules, while acknowledging that nodules represent a morphologic spectrum encompassing both benign and malignant features. Nodule pathology. Arrow indicates a nodule in right lung. Nodule pathology, shape and margin. Nodules can be described as round, ovoid, or polygonal in shape, and as spherical, flat, or elongated in configuration, based on their appearance in various imaging planes. Margin of a nodule can be well-defined, ill-defined, depending on appearance of interface with the surrounding lung. A smooth nodule border is even and free of substantial protrusions or indentations, as opposed to an irregular nodule border. Irregular borders can be lobulated with lobule-like protrusions, lobulation, and/or spiculated with multiple radiating small sharp projections, spiculation. Linear components extending from nodule to pleural surface are called pleural tags. Combinations of above shapes and margins may occur. Nodule pathology. Arrow indicates solid nodule, well-defined nodule, round nodule in left lower lobe. Nodule pathology. Arrow indicates nodule, solid nodule, round nodule, spiculated nodule in right middle lobe. Nodule pathology, calcified. Arrow indicates a nodule, calcified nodule in right upper lobe. Nodule pathology. Arrow indicates a nodule, solid nodule, irregular margined nodule in right lower lobe on coronal CT. Nodule pathology. Arrow indicates a nodule, ill-defined nodule, peripheral nodule. Nodule pathology. Arrows indicate ill-defined margined nodule in left lung. Nodule pathology. Lobulated. Arrows indicate a nodule with lobulated margin. Lobulation. Nodule pathology. Lobulated. Arrows indicate nodule with lobulation. Lobulated nodule in left upper lobe. Nodule pathology. Elongated, calcified. Arrows indicate calcified and elongated nodules of 2 patients. Nodule pathology. Fat calcification. Arrow indicates a nodule with fat and calcification, suggesting hematoma. Nodule pathology, attenuation and structure. Based on attenuation, nodules with pure ground glass attenuation are referred to as ground glass nodules. Nodules with pure soft tissue attenuation are referred to as solid nodules. Nodules with both ground glass and soft tissue attenuation components are referred to as part solid. In the context of the lung adenocarcinoma, the ground glass components generally correspond to a lipidic growth pattern, and solid components generally correspond to invasive growth patterns. The term ground glass, solid, and part solid nodule do not necessarily encompass the entire complex morphology of pulmonary nodules and are also limited by low inter- and intra-observer reproducibility among the radiologists. Nodule pathology. Ground glass nodule, pure and part solid ground glass nodule. On your left side, pure ground glass nodule in right lower lobe. On your right side, part solid ground glass nodule in right upper lobe. Nodule pathology, attenuation and structure. Nonetheless, these terms are established in literature, and it is likely that they will continue to be used despite their limitations, notably for purposes of management and big data categorization. Note that thin section CT is essential for accurate characterization of small nodules. Based on structure, nodules are either simple or complex. Simple nodules show a single structural component, soft tissue, ground glass, calcium, fat. Complex nodules have 2 or more structural components, soft tissue, ground glass, calcium, fat, air. Of note, simple nodules can develop into complex nodules and vice versa. Nodules pathology, location. Nodules can be described as peribronchovascular or centrilobular depending on their location in relation to other structures. See anatomical distribution. Nodules rising from a fissure should be called fissural. Nodules with direct contact to a fissure but not arising from it should be called perifissural. Nodules arising from pleura should be called pleural. Nodules with direct contact to pleura but not arising from it should be called pleura-based. The term subpleural should only be used for nodules in proximity to pleura, but without direct contact to it. Because this term has been attributed variable meanings in literature, the term peripheral is preferred to describe such nodules. Nodule pathology, perifissural. Arrow indicates perifissural nodule of the right minor fissure. Nodule pathology, peripheral. Arrow indicates a nodule of a peripheral location of a major fissure. It is from sclerosing pneumocytoma. Nodule pathology, location. Peripheral is preferred than subpleural. Arrow indicates a nodule of peripheral location. Nodule pathology, location, pleural-based and peripheral located. Black arrow indicates a pleural-based nodule, and white arrows indicate peripheral nodules. Quit smoking? Your great job of the year. Congratulations! This is the final slide. You worked hard, very hard today. Congratulations. See you soon on part 4. You have a nice day. Hey guys, nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we're gonna talk about the Fleischner Society 2024 Glossary of Terms for Thoracic Imaging, Part 5. Let's begin. This topic is based on the radiology, reviews and commentary, statements and guidelines, Fleischner Society Glossary of Terms for Thoracic Imaging by Alexander A. Benkier et al. Radiology 2024 310. This topic is for you who want to know the definition of and the radiographic CAT scan findings of the thoracic diseases. Oligemia, anatomy, physiology, pathology. Oligemia is a focal or diffuse reduction in blood flow and or blood volume. At imaging, pulmonary oligemia appears as a decrease in attenuation and or as a decrease in dimension and number of pulmonary vessels. Imaging signs of oligemia can be subtle and may require comparison with normally perfused lung for accurate detection. Opacity, anatomy, pathology, descriptor. Opacity refers to any focal or diffuse nonspecific area of increased attenuation. The term is a general descriptor that does not indicate the nature of the condition causing the opacity. The term has sometimes been used synonymously with the now obsolete and non-recommended term infiltrate. Organizing pneumonia pathology. Organizing pneumonia is a histologic, clinical, and radiographic entity reflecting a repair mechanism of the lung parenchyma after exogenous or endogenous injury. Histologically, organizing pneumonia is characterized by loose plugs of organizing connective tissue in distal airways and alveoli. The imaging presentation is variable, with sharply defined peripheral or bronchocentric consolidation with or without ground glass, air bronchograms, curvilinear perilobular opacities, nodular opacities, and atol sign being common manifestations. However, numerous additional manifestations and patterns have been described, including peripheral sparing. Organizing pneumonia pathology, atol sign. The arrows in the coronal and axial CAT scan images show the atol sign of organizing pneumonia. Organizing pneumonia pathology, peribronchovascular. Black arrows indicate the peribronchovascular of organizing pneumonia patient. Protracheal stripe anatomy. Right paratracheal stripe, the interface between the right tracheal wall, the adjacent pleura, and the mediastinal fat between them, as seen on frontal chest radiographs. It begins superiorly at the level of the clavicles and extends inferiorly to the right tracheobronchial angle at the level of the azygos arch. Left paratracheal stripe, the interface between left upper lobe and either the mediastinal fat adjacent to the left tracheal wall or the left tracheal wall itself. It extends superiorly from the aortic arch to join with the reflection from the left subclavian artery. Thickening of the stripe on either side may reflect enlarged lymph nodes, hematoma, or another mediastinal pathology. Paratracheal stripe anatomy, right and left paratracheal stripe and obliteration. Arrows on left chest radiograph show right and left normal paratracheal stripes, and arrows on right chest radiograph show obliteration of right paratracheal stripe and bulging of 4R lymph node in sarcoidosis patient. Parenchyma anatomy. Parenchyma refers to the part of the lung tissue involved in gas transfer. The lung parenchyma includes the alveoli, alveolar ducts, and respiratory bronchioles. Parenchymal band pathology. A parenchymal band is a thin linear opacity paralleling the pleura, occasionally described as extending to the pleural surface. It can be associated with architectural distortion and is commonly seen in the context of asbestos exposure. More recently, it has been described as a sequelae of COVID-19 pneumonia and organizing pneumonia. Parenchymal band pathology. Arrows indicate the parenchymal band in right lower lobe. Parenchymal band pathology. Arrows indicate the parenchymal band of another patient in right lower lobe. I appreciate your subscription and like. I hope you to be healthy, wealthy, and happy. Pattern, anatomy, pathology, crazy paving, focal areas of ground glass opacity with well-defined margins, within which septal thickening and intralobular reticular lines can be identified, in a pattern similar to crazy paving stonework. Interstitial, descriptor referring to underlying connective tissue framework of the lung. Biliary, subcategory of nodular pattern designating profuse, diffuse, and randomly distributed, well-defined micronodules of uniform size with diameters of 1 to 2 mm resembling millet seeds. Pattern, anatomy, pathology, crazy paving. Left lower lobe of this COVID pneumonia patient shows ground glass opacity of a crazy paving pattern. Pattern, anatomy, pathology, miliary. Miliary nodules are shown on this left lung of the tuberculosis patient. Pattern, anatomy, pathology, mosaic, patchwork of regions with normal and abnormally increased attenuation, mosaic attenuation, nodular, pattern including nodules, reticular, collection of intersecting linear opacities that produce an appearance resembling a net, sometimes referred to as reticulation, reticular-nodular, combination of a reticular and a nodular pattern. Pattern, anatomy, pathology, reticular. Yellow squares show the reticular pattern. Pattern anatomy pathology reticular. Yellow square shows the reticular pattern. Pattern anatomy pathology reticulonodular. Yellow square and arrows in the magnified image shows the reticulonodular pattern. Pattern anatomy pathology reticulonodular. Arrows show the reticulonodular pattern in lymphatic carcinomatosis patient. Pattern anatomy pathology 3 attenuation, 3 density. Combination of sharply demarcated zones with normal, increased, and decreased attenuation on CT images acquired in inspiration. 3 in bud. Micronodules connected to linear opacities with one or more branching sites, thus resembling a budding tree. Pattern anatomy pathology 3 attenuation. Arrows indicate normal, increased, and decreased attenuation. Pattern anatomy pathology 3 in bud. Arrow indicates 3 in bud appearance in tuberculosis patient. Pleura anatomy. The pleura is a 2-layered serous membrane folding back on itself at hilum that covers both lungs. 2 layers of membrane are separated by a small amount of viscous lubricant called pleural fluid, which causes surface tension and, together with negative pressure, pulls parietal and visceral pleura adjacent to each other. Each pleural layer consists of a monolayer of mesothelial cells and a layer of underlying mesenchymal tissue. Both layers form the virtual pleural space. At imaging, normal pleura is best seen when it forms interlobar fissures or in the presence of extrapleural fat. See anatomic distribution. Pleural anatomy. Parietal pleura is pleural layer that lines the inner surfaces of thorax on each side of mediastinum and can be subdivided into mediastinal, diaphragmatic, costal. Visceral pleura is pleural layer that covers surface of each lung and inserts between lobes of the lung, forming interlobar fissures. The adjectival form pleural is often associated with the following terms: effusion, pathology, excessive pleural fluid caused by mechanical factors, edema, infection, inflammation, or malignancy. Pleural anatomy, visceral pleura. Each arrow indicates right upper lobe, middle lobe, and lower lobe visceral pleura in a pneumothorax patient. Pleural anatomy, pleural metastasis. Arrows indicate the pleural metastasis from lung cancer on left side. Pleural anatomy, pleural and fissural effusion. Black arrows indicate the pleural effusion on lateral side, and white arrows indicate fissural effusion in the right major fissure. Pleural anatomy. On radiographs, small pleural effusion manifests as blunting of the costophrenic angles, often meniscus-shaped, and larger effusions are homogeneous opacities in dependent regions. On CT exam, effusions are of variable attenuation and widen pleural space. CT can depict loculations as well as pleural thickening and hyperemia when performed with contrast enhancement. Plaque pathology. Fibrohyaline focal lesions arising in parietal pleura. Pleural plaques are usually associated with previous exposure to natural fibrous silicates, usually asbestos, At imaging, pleural plaques are well-defined, elevated, flat or plateau-like areas of pleural thickening that often contain calcifications. Pleural anatomy, pleural effusion. Arrows on left chest radiograph shows paraspinal line obliteration and meniscus sign of pleural effusion, and arrows on right film shows costophrenic angle obliteration of pleural effusion. Pleural thickening anatomy, pleural plaque. Arrows indicate pleural plaques, non-calcified and calcified from asbestos exposure. Pleural anatomy, TAC, pathology. One or more coarse linear or band-like strands extending from a structure, for example a nodule or its components, and having direct contact with the pleura or a fissure. Pathologically, pleural TACs are often associated with thickened interlobular septa connecting a structure to the pleura. While usually nonspecific, pleural TACs have also been described as a potential indicator for visceral pleural invasion. Pleural anatomy, TAG. Arrows indicate pleural TAGs from left upper lobe adenocarcinoma. Pleural anatomy, thickening, pathology. Focal or diffuse increase in thickness of pleura, commonly caused by fibrosis following chronic or recurrent mechanical irritation, for example by refracture and by pleural effusion or pneumothorax. Pleural thickening can also be caused by asbestos exposure or infection, as well as by neoplasms such as metastasis, lymphoma, or mesothelioma. Pleural thickening is visible at CT as a softish curvilinear stripe passing internally to ribs and innermost intercostal muscles. Thickened pleura often enhances and is best seen after IV contrast administration. Pleural thickening anatomy, metastasis. Arrows indicate the pleural metastasis. Pleural thickening anatomy, split pleural sign. Arrows indicate visceral and parietal pleural thickening in a chronic tuberculous empyema patient. Pleural thickening anatomy, split pleural sign. Arrows indicate thickened and enhancing parietal and visceral pleura, split pleural sign of empyema. Pleural thickening anatomy, visceral pleural involvement. Arrow indicates pleural involvement due to adenocarcinoma of ground glass opacity. Pleural thickening anatomy, visceral pleural involvement. Arrow indicates pleural involvement, visceral pleural involvement by adenocarcinoma of ground glass nodule. Pleural thickening anatomy, pleural-based. Arrow indicates pleural-based nodule from rib metastasis. Pleural thickening anatomy, pleural calcification. Arrow indicates a pleural calcification, pleural lesion from previous tuberculous pleurology. You quit smoking? Your great job of the year. Congratulations! This is the last slide. You worked hard. You worked very, very hard today. See you soon on part 6. Goodbye. Hello, dear friends. Nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we will talk about the last part 6 of Fleischner Society 2024 glossary of terms for thoracic imaging. Let's start. This topic is based on the radiology, reviews and commentary, statements and guidelines, Fleischner Society, glossary of terms for thoracic imaging by Alexander A. Benkier et al. Radiology 2024, 310. This topic is for you who want to know the definition of and the radiographic CAT scan findings of the thoracic diseases. Let's start. Pneumatocoel pathology. A pneumatocoel is a thin-walled, gas-filled cystic structure in the lung parenchyma. Pneumotocoels can be caused by pneumonia, trauma, including barotrauma, or aspiration of hydrocarbon fluid. For example, in fire-eating, pneumatocoels can be transient and are likely caused by a combination of parenchymal necrosis and a check valve airway obstruction. At imaging, pneumatocoels appear as rounded, thin-walled cystic lesions in the lung parenchyma, sometimes with an air fluid level. Pneumatocoel pathology. Arrows indicate pneumatocoel with air fluid level in axial and coronal reconstruction CT images. Pneumomediastinum pathology. Pneumomediastinum is an abnormal collection of air or gas in the mediastinum, outside of the esophagus and tracheobronchial tree. It can be caused by a spontaneous rupture of alveoli, by trauma, or by esophageal rupture with a subsequent incursion of air along the axial interstitium into the mediastinum. It is most often associated with surgical trauma, barotrauma, or conditions related to prolonged cough, such as asthma or interstitial lung disease. At imaging, pneumomediastinum appears as one or more low attenuation areas of linear or band-like air collections outlining mediastinal structures. Pneumomediastinum pathology. Arrows indicate the outside, outlining the tracheobronchial wall, indicating pneumomediastinum. Pneumomediastinum pathology. White arrows indicate pneumomediastinum, and black arrows indicate right pneumothorax in interstitial lung disease patient. Pneumomediastinum pathology. Arrow indicates continuous diaphragm sign of pneumomediastinum. Pneumomediastinum pathology. Angel wing sign, spinnaker sail sign. Arrows indicate angel wing or spinnaker sail sign of pneumomediastinum in a neonate. Pneumonia pathology. Commonly used diagnostic term that typically designates infection of the lung parenchyma. Pneumonia can be caused by bacteria, virus, fungi, parasite, or other microorganism, and can be focal or multifocal. Pneumonia can manifest as opacity, potentially accompanied by air bronchograms, tree-in-bud opacities, or pleural effusion. Pneumonia pathology. Arrow indicates opacity with air bronchograms in left lower lobe, showing us pneumonia. Pneumonitis pathology. Pneumonitis is a diagnostic term that designates inflammation of the lung parenchyma, both infectious and non-infectious. Infectious pneumonitis is generally referred to as pneumonia. Non-infectious pneumonitis can be caused by a wide range of conditions, including aspiration, hypersensitivity, radiation, autoimmune disease, and drugs. The term pneumonia and pneumonitis are sometimes used interchangeably, but the above definitions are preferred. Pneumopericardium pathology. Pneumopericardium is the accumulation of air in the pericardial cavity. Pneumopericardium has been described in preterm neonates or in the context of mechanical ventilation in infants. In adults, it is usually due to trauma or cardiac surgery. It can be associated with other pathologic air collections such as pneumomediastinum or pneumothorax. At imaging, pneumopericardium manifests as air or gas attenuation in the structureless space separating the two layers of the pericardium. Pneumopericardium pathology. Arrows indicate pneumopericardium after cardiac surgery. Pneumothorax pathology. Pneumothorax refers to presence of air or gas in pleural space that separates the parietal and the visceral pleura. Therefore, parts of the lung can partially or completely collapse. Pneumothorax can be caused by spontaneous rupture of flaps or by mechanical trauma, including iatrogenic damage. The diagnosis of tension pneumothorax is determined by clinical and physiologic criteria that typically correlate radiographically with contralateral mediastinal shift, depression of ipsilateral hemidiaphragm, most often based on a check valve mechanism. Ultimately, definitive diagnosis of tension pneumothorax is determined by clinical and/or physiologic criteria. Pneumothorax pathology. Arrows indicate right lung pneumothorax, showing us visceral pleura of the collapsed lung. Left filum is inspiration filum and right filum is expiration filum. Pneumothorax pathology. Black arrow indicates right pneumothorax and white arrow indicates emphysema on left upper lobe. Pneumothorax pathology. Arrow indicates a spontaneous pneumothorax in an interstitial lung disease patient. Pneumothorax pathology. Arrow indicates tension pneumothorax in right lung. Pneumothorax pathology. Pneumothorax is typically identified on upright chest radiographs by the presence of a curvilinear visceral pleural line, indicating the demarcation between pleural air and aerated lung. However, on radiographs acquired in the supine position, when the separated pleural surfaces are not tangential to the X-ray beam, pneumothorax may be difficult to detect. In these cases, ancillary findings such as unusually sharp interface between lung and mediastinal or cardiac structure can be helpful. The deep circle sign refers to an abnormally deepened costophrenic angle which has low attenuation and is abnormally sharply defined. Pneumothorax pathology. Deep circle sign. Two white arrows indicate deep circus sign. One vertical arrow indicates sharp interface of diaphragm due to Mach band effect. Black arrow indicates normal side of diaphragm. Saber-sheath trachea pathology. Saber-sheath trachea refers to the abnormal shape of trachea with an increased sagittal AP and a decreased coronal left and right diameter, which resembles the sheaths of a saber. To meet the definition, the internal coronal diameter of the trachea must be less than 2/3 the sagittal diameter at the same anatomical level without any extrinsic cause of compression. Saber-shaped trachea is most commonly seen in patients with COPD and is assumed to be the result of chronic inflammation and subsequent remodeling of the tracheal wall. Saber-shaped trachea. Arrows indicate saber-shaped trachea in an emphysema patient. You subscribed and liked. Thank you very much. Be healthy, wealthy, and happy. Secondary pulmonary lobule anatomy. A secondary pulmonary lobule is the smallest structural unit of the lung parenchyma, surrounded by a connective tissue sheath. It is irregularly polyhedral or pyramidal in shape, with borders ranging from 5 to 25 mm in length. It contains 3 to 25 acini. The structures in the center of the secondary pulmonary lobule, core structures, centrally lobular structures, include bronchioles and their accompanying pulmonary arterioles and lymphatic vessels. The connective tissue envelope of secondary pulmonary lobule contains veins and lymphatic vessels. The secondary pulmonary lobule also has an internal support structure, intralobular interstitium. CT can help visualize the three basic components of secondary pulmonary lobule, namely central structures, region where acini are located, and connective tissue sheaths that forms interlobular septa. If you want to know more about the secondary pulmonary lobule, please refer to this paper, Ito Harumi et al., Diffuse Lung Disease, Pathologic Basis for HRCT Findings, Journal of Thoracic Imaging, 1993, Volume 8. Secondary pulmonary lobule anatomy septum. Arrows indicate two secondary pulmonary lobules in right middle lobe and right lower lobe. Secondary pulmonary lobule anatomy septum. Arrows indicate secondary pulmonary lobule in an interstitial pulmonary edema patient. Secondary pulmonary lobule. Arrows indicate secondary pulmonary lobule. Right side film shows thickened secondary pulmonary lobular septum in interstitial pulmonary edema patient. Secondary pulmonary lobule anatomy. Arrow indicates secondary pulmonary lobule in a lymphatic carcinomatosis patient. Segment anatomy. Segment is the structural unit of a lobe ventilated by a segmental bronchus, perfused by a segmental pulmonary artery, and drained by an intersegmental pulmonary vein. The right lung has 10 segments, with 3 in upper lobe, 2 in middle lobe, and 5 in the lower lobe. The left lung has either 8 or 10 segments, depending on whether apical posterior upper lobe segment and anteromedial segment in left lower lobe are considered to represent 1 or 2 segments. At imaging, individual segments are identified inferentially based on the position of supplying segmental bronchus and artery. Occasionally, segments can be separated by accessory fissures. Septum, pleura, septa, anatomy. Septum is a sheath-like connective tissue structure surrounding secondary pulmonary lobule. Because they separate lobules, they are also referred to as interlobular septa. They contain veins and lymphatic vessels. Being oriented perpendicularly to the pleura, isolated septal lines can be occasionally seen on CT exam in otherwise healthy patients, and the lung apexes and bases as thin linear structures separating secondary pulmonary lobule. They are more conspicuous when thickened in interstitial edema. The adjectival form septal is commonly used with the following terms: line anatomy, linear structure representing an interlobular septum. Septum, pleura, septa anatomy. Arrows indicate septum in right lower lobe. Septum, plurosepta, anatomy, thickening, pathology, seen on chest radiographs and CT exam as thin linear structures at right angles to and in contact with lateral pleural surfaces, formerly referred to as curly lines on radiographs, an obsolete and non-recommended term. They reflect the accumulation of fluid or tumor in the interstitium. For example, in pulmonary edema, lymphangitic carcinomatosis, and/or mechanical lymphatic obstruction. On CT exam, septal thickening can be smooth or nodular, which may have to differentiate edema from lymphatic infiltration or obstruction. Septum, pluroseptal anatomy, septal thickening. Arrows indicate septal thickening on frontal radiograph, formerly called as curly lines. Septum, pluroseptal anatomy, septal thickening. Arrows indicate septal thickening in coronal CAT scan in lymphangitic carcinomatosis patient. Signet ring sign pathology. Signet ring sign refers to ring-shaped structure representing a dilated bronchus, imaged perpendicularly, accompanied by a smaller adjacent rounded and dense structure representing accompanying pulmonary artery. The combination of both resembles a signet or pearl ring. It is considered typical of bronchiectasis, but can also be seen in diseases with abnormally decreased pulmonary arterial flow, for example, chronic thromboembolic disease or proximal interruption of the pulmonary artery. Signet ring sign pathology. Arrow indicates a signet ring sign of bronchiectasis in left lower lobe. Silhouette sign pathology. The silhouette sign refers to obscuration of a normal silhouette or interface and results from the juxtaposition of structures with a similar radiographic attenuation that obliterate normal anatomic borders or interfaces. However, it is not always indicative of pulmonary disease. For example, obscuration of the heart border can sometimes be caused by anatomic variants such as pectus excavatum. Silhouette sign pathology. Arrows indicate right heart border, preserved right heart border. Left chest radiograph shows silhouette sign positive of right middle lobe pneumonia. Radiograph on right side shows silhouette sign negative of right lower lobe pneumonia. Silhouette sign pathology. Arrows indicate preserved normal left heart border. Chest radiograph on left side shows silhouette sign positive left upper lobe pneumonia, and chest radiograph on right side shows silhouette sign negative left lower lobe pneumonia. Small airway disease pathology. This umbrella term summarizes diseases of peripheral airways. The definition of term vary. Some radiologists consider small airways as those with an internal diameter of less than 2 mm and wall thickness of less than 0.5 mm. Others place demarcation between central and peripheral airways at the level of a bronchiole. Although two definitions are not consistent, the first one appears more practical and is more commonly used in the literature. On CT exam, these diseases can manifest as peribronchial and/or bronchial abnormalities, including 3-in-bird opacities, centrilobular micronodules, air trapping, bronchial ectasia, oligemia, or a combination of these findings. Speculation, pathology, descriptor. Speculation is a descriptive term referring to multiple fine linear strands extending from a structure, for example, nodule or its component, into the surrounding lung parenchyma in a stellate manner. Pathologically, speculations are often associated with a desmoplastic process, for example, an invasive malignancy, within nodule resulting in fibrotic strands radiating into the surrounding lung. Speculations can also be associated with direct infiltration into adjacent bronchial or vascular structures or focal lymphangitic extension. Speculation in a nodule increases the likelihood of cancer, although it is not specific. Speculation, pathology, descriptor. Arrows indicate speculations of right upper lobe adenocarcinoma. Speculation, pathology, descriptor. Arrows indicate speculation of right upper lobe non-small cell lung cancer. Tracheomalacia, tracheobronchomalacia, pathology. Terms tracheomalacia and tracheobronchomalacia are used when there is excessive inward movement of the trachea and or main bronchi during expiration due to pathologic weakness of cartilaginous airway wall. The closely related term excessive dynamic airway collapse is used when tracheobronchial collapse is due to excessive invagination of posterior muscular trachea or main bronchial walls during expiration. Both entities can be diagnosed with dynamic expiratory CT. However, it is important to be aware that in healthy individuals, the trachea may collapse by 70% or more during a forced expiration. Tracheobronchomalacia pathology. Arrow indicates tracheomalacia. You quit smoking? Wonderful. Your great job of the year. Congratulations. Now you finished part 6. Wonderful job. Great is the job. Congratulations. See you soon again on total of glossary of the thoracic imaging.